professor e chefe do Departamento de Medicina Comunitária na Escola Médica do Noroeste da Índia. Além de professor, ele também é gerente de 2 centros de saúde urbano e rural no estado de Uttar Pradesh, na Índia. É uma figura pública que recebeu vários prêmios, incluindo o prêmio de chefe do ministro pelas contribuições na gestão da crise da Covid. Vamos contar também com a ilustre participação da Camila Maia Franco, que é sanitarista, psicóloga organizacional, mestre em saúde coletiva pela Universidade Federal Fluminense e atualmente subsecretária da Saúde do município de Niterói. Infelizmente, a doutora Nor Bari, que é bacharel em ciências, em medicina e cirurgia, especialista em doenças infecciosas e em emergência, teve um contratempo no último minuto e não poderá estar presente conosco. Mas, para iniciar o nosso debate, gostaria, então, de convidar o Dr. Sunil Raina para apresentar a sua experiência Minha Cidade, Livre do Corona, no estado de Uttar Pradesh, na Índia, lembrando que se trata do maior estado, do estado mais populoso da Índia, com 220 milhões de habitantes, ou seja, um estado que tem a mesma população de todo o Brasil. Então, vamos passar e vamos agradecer desde já a presença e passar a palavra para o Dr. Sunil Raina apresentar a experiência que ele vem liderando no estado de Uttar Pradesh, na Índia. Por favor, Dr. Sunil Raina, a palavra é sua.
Am I supposed to share the screen now? Or
yes,
somebody...
please.
Yes, yeah. Okay. Now, first, thanks a lot, Luis. I did not understand a lot of this. This was probably Portuguese, if I am correct. The language that was spoken. So I didn't understand it, but the last part of it I did understand. It was Sunil Rana, and so I thought it is my time to come into the show. So a very good afternoon from India, but a very good morning to everybody in Brazil. This may be a very beautiful morning in Brazil. This is about my institution from where I come. I come from an institution which is in the lap of Himalayas in northern part of India. And this is a picture of my institute. Now, the basic crux or the basic point of discussion for this particular webinar is, has India been successful or has India been partially successful? And if it has been partially successful, what have been the probable reasons for that? We will talk about certain highlighting points or talk of certain points which may have worked in India's favor, despite the fact that we did have a lot of casualties and we didn't do as well as one would have wanted us to do. But that has been the case with regard to this pandemic across the world. None of the countries across the world can claim 100% success as far as this pandemic is concerned. So therefore, looking at India's success in the larger gamut of how the entire world has fared as far as this pandemic is concerned, is something that can be helpful to all low and middle income countries across the world when they plan to mitigate the impact of a pandemic like this in future, or for that matter, when they are planning to get rid of this pandemic at this present point in time. I do accept the fact that we have lost lives, but we did have some partial success. At least now in the second part of the pandemic, the way our numbers are throwing up, the way India's numbers are throwing up, we had some 12,000, 13,000 cases last day. We have been having such number of cases for last 2 months now. And large part of the states, large part of the country are not showing high numbers. If you look at the map that India has, and if you look at the numbers that come in India, most of these are restricted to few geographical areas. Most of these are restricted to few states only. Rest of India is almost reporting no cases or a very few cases. For example, our capital city, Delhi, is reporting numbers in 2 digits, very small numbers. But our focus for this talk will be on a state which is as populous as you probably said in your opening remarks, is as populous as Brazil. So we will be focusing on Uttar Pradesh, which has a population in excess of around 200 million people. How this state, which is largely not considered to be high on resources, not considered to be very high on infrastructure as far as health is concerned, been able to keep the numbers to the levels that it has now for a long period of time. So probably that is where we will continue our discussion on. So I just made a small slide for a general view. How exactly does it work? So this is something that I have made. To be very honest and fair with the people who listen about this, there have been few things that have worked in India's favor, and these few things have also worked in favor of Uttar Pradesh as far as this pandemic is concerned. We will talk of those things later, which worked in its favor. We will talk of the things that the government, over a period of time, initiated to reduce the numbers of COVID-19 cases in Uttar Pradesh. So for that, first we will talk of restrictions on travel and lockdown. Now, when India had its first peak, which was earlier in the part of 2020s, the restrictions were imposed across the country in the first part of the pandemic only. So we did see restrictions and lockdowns in country by the end of March 2020 only. But these restrictions over a period of time were reduced. The impact of these restrictions was reduced. And by the end of October and November 2020, we saw that most of these restrictions were more or less removed across the country. The cases in India were falling, and by February 2021, the number of cases in India was around 10 to 11,000. And that's when the problem started. So India, probably in a mode of early celebration, started thinking that we have won over the pandemic and started opening up entirely. We did have small amount of restrictions. For example, schools were not fully open till then in all parts of the country. But by then we thought that we should open up everything. We should open up offices. We should open up schools. We should open up industries, and we should open up we should also allow those people who work from home to go back to the offices. What that did was that by May, we were into the second peak of the pandemic, and we started seeing a high number of cases which touched more than 400,000 a day, which we saw the highest levels which touched was around 400,000 a day in India. And most of the parts, including Uttar Pradesh, the state of which I am talking about, went into a lockdown again. Now, this time the lockdown was different from the one which was used in the first part of the pandemic. Now, in the first part of the pandemic, the lockdown was national and was enunciated or was promulgated by the central government or the federal government. At this point in time, every state government was allowed to have their own lockdowns. They had to develop their own guidelines for that. So what UP did was that they planned a lockdown which will have an impact in the sense that a weekend lockdown will be there. So on Friday, they will start the lockdown. So Friday, Saturday, and Sunday will be closed down, and Monday morning people can go for doing some amount of jobs. Not all jobs were opened up. In addition to that, the lockdown also ensured that there were night curfews, so that nobody is allowed to move out of his home after a fixed period of time. Initially, it was 7 p.m., then it was extended to 8 p.m., and lately it has been extended to 10 p.m. So the restrictions were there for night movements, the restrictions were there for day movements from Friday to Monday morning, and restrictions on opening and closure of shops were there. They were allowed to open for a fixed period of time, and they had to adhere to the broader guidelines of using masks, as was suggested previously as well. They had to use masks, keep sanitizers at their disposal, and had to use social distancing as a part of their processes. And there was a fixed number of entries that were allowed in a shop. So that is something that was there as part of the lockdown. But very important as part of this lockdown was restrictions on travel from one district to another district of the state, and restriction in travel from one state to another state. So for example, Uttar Pradesh did not allow everybody from across the country to enter its state. And when it did allow people to enter its state, it had a reason for them to enter. So anybody who had an emergency situation, for example, his father or mother falling sick and the child wanting to visit his parents, so he had to get his RT-PCR done and show his RT-PCR test negative result at the entry place to Uttar Pradesh. And if he was RT-PCR negative, he was allowed to enter into the state. And once into the state, he was asked to undergo a mandatory quarantine at his home if he was RT-PCR negative, and if he was RT-PCR positive and he wanted to enter in the state, he had to undergo a mandatory institutional quarantine in the state. So these were the part of the restrictions which continued to stay in effect till very late this year. So in fact, most of these restrictions were there in place till September, when the number of cases in Uttar Pradesh had fallen down to 2 digits only. In addition to these restrictions on travel and lockdown, one another important thing that was enunciated by Uttar Pradesh government, as also the other parts of the country, was closure of schools. So as I keep saying that one important thing which happened in India across this period of time, that schools mostly stayed closed. Not just the schools, the colleges stayed closed, the universities stayed closed, and most of the teaching and training under these schools or colleges was undertaken at the level of online platforms only. Very recently, Uttar Pradesh has allowed schools to open, but has asked for an attendance of only 50%. So if a class had 30 students, it has asked the teachers or the school management to allow only 15 students to come on a daily basis. Rest of the students can attend the class online. They can stay home and attend the class online. One important thing in addition to this was the fact that people till now have been allowed to stay home, and attendance is not mandated for appearing in exams. So for example, if a student has not attended school during this period of time and is appearing in his exams, he is allowed to sit in his exams despite the fact that he may not have attended classes for a fixed period of time, which is otherwise mandatory for attending a class, attempting exams. So these two things were something that were done anew or afresh as a part of the management of this COVID in the second phase, as also this was done in the first phase. But there are other things that may have been helpful as far as COVID is concerned in Uttar Pradesh. A large part of this could be attributed to the fact that the basis or the construction or the platform for this was laid down by certain other things that had already been happening in Uttar Pradesh as well as the entire country. Now, people keep asking me one question. They ask me that despite being so poor, how did India go into a lockdown and ensure the fact that its citizenry was able to have its livelihood? So the fact is that there are certain schemes, social service schemes that run across India, and they have been there since long time now. Some of them have started in the late 90s, and they have been extended in the early part of 2000, or as late of 2011 and 2016. Now, what do these schemes do? One of the schemes that I will talk about and I'm interested in talking about is known as the Antodaya Yojana, which means that Antodaya Anna Yojana, AAY. Now, Antodaya means the last person on the street or the last person in the country, and Anna means the ration. So what does this AAY scheme mean, or Antodaya Anna Yojana mean? It means that a large population of India's people who are below poverty line are provided rations at a subsidized rate. So if you look at it this way, that around 75% of India's rural and 50% of India's urban population is covered under this Antodaya Anna Yojana. A substantial part of this rural and urban population, which falls below the poverty line, which falls under the poverty line, is provided these rations in terms of rice and wheat at the rate of less than 3 cents per kilogram, which is very small. So they can purchase these ration at a very small price of less than 3 cents per kilogram, whether they want to purchase rice or they want to purchase wheat or other coarse grains. The other coarse grains that cost little lesser than this. If rice costs around 3 cents, the wheat costs around 2 cents, other coarse grains cost around 1 cent only to these people who are below poverty line. Now, what Uttar Pradesh, as well as the entire part of the country, did was that they extended this scheme, which was already in existence across the country. What they did was that instead of levying some cost on this rice grains or the food grains that are being made available at a small premium, they said that they will provide free of cost rations at the rate of 3 to 5 kilogram per person, per family. So 5 kilogram per person, per family was supposed to receive free rations through this scheme only. So instead of having to pay for those amount of rations, they will receive these rations free of cost. And this scheme has been extended to September. This was extended to September of this year only. You'll be surprised that around the country, more than 800 million people have benefited from this scheme only. So 800 million people have received free food at the rate of 5 kilograms per person per person per month per family have received this food till September. So that has been one program, or that has been one scheme that has been able to help people live through while there was lockdown or where there was restrictions in people conducting their work. Now, in addition to this scheme, which is the AIOS scheme, during all parts of lockdown, it was ensured that the agricultural practices that people were involved in did not go the lockdown way, or there was no restriction in performing agricultural practices. So anybody who was sowing seeds could do it. Anybody who was doing cultivation, he could do it, and restrictions were not on there on that practice. So agriculturists were more or less immune to lockdown. And in addition to agriculture is the fact that small scale industries or small workers were also slightly under less pressure as far as this lockdown was concerned. So the livelihood was ensured through these three schemes. One, the fact that they were extending an existing scheme and ensuring that food was made available to others. Two, the agriculturists were allowed to carry on with their work throughout this period of lockdown. And three, the small workers, the daily wage workers who were working on a plant, who were working on a factory, or who were working on site for construction, they were allowed to go to these places despite imposition of lockdown or restrictions. So this was something that was done anew through extension of the existing schemes, as well as the thought process that ensured that people didn't lose their livelihood during these lockdowns. Now, in addition to this ensuring lockdown, what UP did was this Mukhyamantri Bal Seva Yojana. This was something that was unique to Uttar Pradesh, and no other state probably thought of it at that point in time when Uttar Pradesh envisaged it. Now, what they did was that they thought that anybody or any person, any family who loses their earning member, or any kid who loses his father or mother, they are entitled to this Mukhyamantri Bal Seva Yojana. Under this yojana or under this scheme, what do they get is that a child who has lost his father or mother is directly under the patronage of the state, and they receive a financial assistance of around 4,000 rupees, 4,000 Indian rupees per month. 4,000 Indian rupees is roughly, what I would say is around 600 or 60 US dollars, sorry, 60 US dollars. So they will get that on a family basis. Per person will get that from the Chief Minister's Relief Fund. In addition to that, they are giving free support for education. And if any of these is of the marriageable age, and because of the fact that they have lost the earning members, the family is not there to support them in marriage, it's the job of this Mukhyamantri Bal Seva Yojana that this marriage will be done. So this was another step that was taken up by Uttar Pradesh to ensure that people are able to take care of themselves during this lockdown, and are able to submit to the guidelines that are being taught from, or that are being planned or envisaged from time to time. Because once you have people who realize that their livelihood is ensured, and if there are deaths in the family, they won't have problems with regard to how exactly they will function from now onwards. Their chances of looking up to guidelines or following guidelines or submitting to guidelines and restrictions is much better than if there's a problem with these two issues. The third and the most important thing that Uttar Pradesh did was Mera Gaon Corona Mukt, which was the title of the talk, which is My Village Corona Free. Now, this was something again unique to Uttar Pradesh. In fact, this was started by some other state. The Gujarat state had started this earlier, but the extension and the scale with which Uttar Pradesh launched it was mammoth. It was unprecedented across the country at that point in time. Now, you can imagine the fact that around 70,000 villages in Uttar Pradesh were covered under this Mera Gaon Corona Mukt scheme. And every village was tracked on food, and these ASHA workers who are accredited social health activists, in addition to ANMs, which are auxiliary nurse midwives, they traveled the breadth and the length of Uttar Pradesh villages and tracked, traced, and tested most of the villages there and in their homes only. So what it did was it did two things. At one point in time, it was able to gauge the amount of pandemic that is there, the amount of impact of pandemic that is there in the rural areas of India and rural areas of Uttar Pradesh. Because it was being thought that even if India is able to take care of the urban areas of its urban areas, it may have some difficulty in tackling its rural areas, because the reach of healthcare in rural areas is not of the same level as it is of urban areas in India. So in that sense, this Mera Gaon Corona Mukt Village was a great initiative, and these Ashas and ANMs did a very fabulous job by tracking, testing, and identifying all those who were there in these villages and were probably sick or not sick. So what they did was they carried out screening in their houses through use of pulse oximetry. They carried pulse oximetry and thermometer with them and had a small questionnaire sort of a thing with them, wherein they would ask for recent onset of acute respiratory infections, use pulse oximetry to check for the level of symptoms in terms of oxygen saturation, will look for temperature, if the person had fever or not, will look for other symptoms like cough or other symptoms which were evident of existence of COVID-19. And if they could suspect somebody as being a patient of COVID, they would immediately call the nearest health facility person, and that health facility person will come test them for COVID-19. And if there was a chance that this person is COVID-19 positive and is sick, and they would transfer him to the nearest health facility. If the patient was COVID-19 positive, but was asymptomatic or had very mild symptoms, so that person was allowed to stay home. Now, what this did was that, in essence, was that it reduced the migration of rural population from rural Uttar Pradesh to the urban Uttar Pradesh. And while this migration stopped, the chances of infection traveling from one place to another reduced. The travel restrictions were more strictly followed, because people would get their healthcare needs being fulfilled at their rural level only. So that was probably one of the most important aspects of initiatives that was taken up by Uttar Pradesh through Mera Gaon Corona Mukt. This is just an example of how they tracked these villages and what did they do with regard to each and every detail that is being filled in this form. This is the form for the month of May that was used in the month of May. And you could look this on the left hand side, it is in Hindi. I'm just trying to translate it. This is the name of the block or health area, a geographical area, name of that. Then this is the number of households that are there. And third is the team which has visited and has seen the number of houses there, and how many of these villages they have identified, how many of them have received vaccines, the first dose and the second dose, and how many of these have identified patients with infections, chances of COVID-19 infection. So, for example, they have pointed out first in column it's fever. So, how many of them have been identified with fever in this particular block? How many of them have been found with acute respiratory infections in this particular block? How many of them have had shortness of breath as far as this particular block is concerned? Or how many of them have had symptoms of symptoms of gastrointestinal symptoms with regard to, in addition to the fact that they have fever. So this all is listed for each block by these ASHA, accredited social health activists, and ANM, and this is submitted to the chief medical officer of the area. So this has to be filled across all blocks, across all villages, and the report had to be submitted to the chief medical officer on a daily basis. And this was a key component of this Mera Gaon Corona Mukt village initiative. So this was some other initiative that was taken up by Uttar Pradesh in consultation with UNICEF. And under this process, what they thought was, this was late in the second part of the COVID-19 pandemic, or second wave of the COVID-19 pandemic, when it was being thought of that the third wave is going to mostly impact the children. So what did they do was that they created a 10-part series or 10-episode series on the impact of COVID on a family, and this was relayed across national televisions and other private channels in Uttar Pradesh, wherein a 7-year-old protagonist, 7-year-old girl protagonist, would talk about the importance of, for example, hand washing with soap in one episode. She would talk about social distancing and use of mask in another episode, engagement and learning during long lockdown. This was a part of the third episode. So this was all a part of Tara Hai Taiyar or Tara is Ready. There were 10 episodes, all of which were being relayed on national television or a private broadcaster who was willing to relay them across Uttar Pradesh. The reach was huge as far as this program was concerned. So this is something that I have thought what every other low and middle income country should be doing if they have to take care of this pandemic or a pandemic of similar nature. So the governments have to involve, and governments have to involve these community-based organizations and village health guides sort of a thing. Create a team which build a community-based team, and this community-based team can be composed of community healthcare worker or community volunteers who are going to do the same job which was done by people in the villages of Uttar Pradesh. Pick up symptoms, pick up people who may have symptoms and report this to the nearest health facility so that the load on health facility is reduced, so that the load on healthcare workers is reduced. And this is pretty easily done because of the fact that all of us know everybody else in the villages or in our nearest geographical vicinity. So it may not be a difficult job. And this community-based team can be empowered. It should be tasked to create awareness, create participation, organize events which will be able to again create awareness. They should be there to implement decisions in terms of who exactly needs to be taken to the health facility, and this delivery of healthcare can be a basic part of it can be entrusted to them only. Thank you. That's all from my side. If there are any questions, I am more than willing to answer them. I took a little longer time than I was supposed to. I'm sorry for that.
Thank you very much, Dr. Sunil. You can choose the channel, the English channel in the platform Zoom.
Okay, where it is?
So you can follow the next presentation by Dr. Camila Franco.
How do I do that? How do I follow this English channel?
In the bottom of the platform Zoom, in the line bottom, you have a globe, an icon with a globe, and you have three options: off, English, and Portuguese.
Okay, got it. Yes. Okay, English, and I've chosen English. Fine. Thank you.
Pronto, agora você consegue ouvir bem a tradução?
Yes. Okay, I'm getting
great.
it in English now.
Ok. Muito obrigado pela sua apresentação, Dr. Sunil. Excelente panorama da estratégia da eliminação do coronavírus e que traz pontos importantes para a reflexão no Brasil. O Brasil tem um programa de agentes comunitários de saúde, que é também bastante extenso, mas enfim. Mas antes das perguntas, vamos ouvir a doutora Camila Franco, a quem desde já agradeço a participação. Ela que tem experiência tanto acadêmica quanto experiência de gestão de saúde, vai poder certamente enriquecer muito o nosso debate. Por favor, Camila, a palavra é sua.
Obrigada, professor Luiz Eugênio. Bom dia, Sunil. Um prazer ouvi-lo contar, né, da experiência. E enquanto ouvia, eu pude estabelecer vários nexos, né, várias relações com a experiência do município do qual eu faço gestão. É um município de Niterói, é um município com 515 a 550 mil habitantes, ou seja, imagina, né, uma proporção muito menor do que a experiência relatada por vocês. Mas, mesmo assim, no parte da gestão, nós partimos de pressupostos muito semelhantes para o enfrentamento ao Covid-19. Então, quando você traz, né, a questão do lockdown, a gente não tinha nenhuma dúvida de que as medidas de lockdown, junto com barreiras sanitárias, eram medidas necessárias naquele primeiro momento, ainda no ano de 2020, para a gente conter a velocidade da transmissão do vírus e, mais do que isso, conseguir organizar o nosso sistema de saúde para receber, né, os doentes que viriam se acometer da Covid. Então, para que o sistema não entrasse em colapso, foi uma luta contra o tempo. E isso só foi possível porque, nesse momento, nós decretamos o lockdown com o fechamento de várias atividades produtivas, permanecendo apenas poucas atividades essenciais em funcionamento, com escalas ainda reduzidas, e dessa forma fomos também um município com maior índice de isolamento social da região metropolitana, o que trouxe um destaque para a gente na velocidade com que a epidemia, com que o vírus entrou no nosso município. Isso fez com que a gente organizasse o sistema de saúde e em nenhum momento esse sistema entrou em colapso, embora vivemos momentos muito tensos, principalmente na segunda onda, que veio com algumas características bem diferentes, né? Então, assim, muito me surpreende. A nossa capacidade de ter as barreiras sanitárias com os... Niterói é um município que fica separado por uma ponte da região da capital do estado do Rio de Janeiro, ou seja, que é uma capital com 8 milhões de habitantes, que tem outras características. Então, nós não estamos isolados, né? Somos urbanos, né? Não temos grandes áreas. Então, nesse sentido, as barreiras sanitárias que colocamos, evitando o trânsito de um município ao outro, controlando esse trânsito, em alguns momentos restringindo para moradores ou trabalhadores da localidade, também foi importante. E aí eu fiquei pensando um pouco, né, quando o senhor traz, né, dialogando com a experiência de vocês aí, como que vocês fizeram as estratégias de proteção das áreas rurais? Porque a gente sabe que as áreas rurais, elas tinham maior vulnerabilidade, não por uma questão geográfica, mas por uma questão de acesso ao serviço de saúde. Um agravamento do Covid dentro dessa área rural, ele é muito mais difícil da gente conseguir atender a tempo hábil do que dentro de uma área urbana específica. Então, eu fiquei pensando, né, nessas estratégias de barreiras, como que vocês determinaram, mesmo com o lockdown. A questão da sobrevivência, que você trouxe de uma maneira muito clara, muito assertiva, e para a gente também esse era um desafio enorme. Para a gente conseguir ter altos índices de isolamento social e manter o lockdown, era preciso, desde o início, garantir a subsistência dessas pessoas. Ou seja, a segurança alimentar, a renda básica. Então, isso para a gente ficou muito claro. Então, aqui no município, nós também adotamos estratégias para essa garantia a partir de benefícios para a população, como entrega de cestas básicas, que são alimentos, na sequência, um cartão, que é como se fosse um vale alimentação, onde as pessoas poderiam fazer as compras nos mercados, né, dos alimentos, e a parte e alguns benefícios que, dessa forma, criava-se uma renda básica para que a população permanecesse em casa. Uma segunda, né, uma próxima preocupação que a gente tinha era da manutenção da economia. Como que a gente vai manter, fazer uma retomada econômica se a gente não cuidasse, né, dos processos produtivos e econômicos durante o processo de lockdown e o processo de maior agravamento da Covid? Daí nós fizemos alguns programas muito importantes de proteção econômica das empresas, com garantia dos empregos, com auxílios diretos e financeiros às empresas. Dessa forma, quando chegamos no momento em 2021, da retomada econômica, a gente não teve uma alta de desempregados. Isso possibilitou com que a gente fizesse esse diálogo da retomada, da flexibilização de uma maneira mais tranquila e mais segura, né? Isso é uma das preocupações nossas também. Nesse sentido, eu vejo os aglomerados urbanos como um grande desafio, porque tem a questão arquitetônica dos nossos aglomerados urbanos, com as residências muito próximas, sem ventilação adequada, a questão em alguns espaços, a questão da dificuldade da entrada, né, do serviço público, da presença do governo, e a vulnerabilidade socioeconômica que esses aglomerados também têm. E, nesse sentido, foi um desafio muito grande para que a gente conseguisse conter a epidemia e conter a transmissão, porque a primeira hipótese era: esses aglomerados vão explodir de casos e, na sequência, de óbitos, por todas essas características que eles têm. Então, quando as medidas de rastreamento e busca ativa de casos nesses aglomerados foi fundamental. A experiência que o senhor relata dos agentes de saúde que foram, né, fazendo essas medidas de rastreamento, testagem, orientação, nós vivenciamos aqui no município de Niterói com o programa médico de família, onde os agentes comunitários de saúde faziam esse processo de busca ativa de casos e rastreamento. Foi quando percebemos que, muitas vezes, a gente indica o isolamento, a quarentena, mas essas pessoas não tinham lugar para realizar essa quarentena, né? Pelas características dessas residências, né? Muitas vezes você tem família inteira num único espaço. Foi quando nós criamos os centros de quarentena assistida, ou seja, era um centro todo organizado, ele aconteceu dentro de um espaço de uma grande escola que temos aqui, e nós organizamos os fluxos e organizamos todo o processo do centro de quarentena, que era um lugar para receber essas pessoas que estavam positivas, precisando se afastar dos seus familiares, fazer essa quarentena no processo de recuperação, para que depois retornasse para dentro dessas comunidades. Então, esse centro de quarentena, ele serviu como um suporte para possibilitar essa quarentena de maneira adequada e correta. E todas essas medidas possibilitaram com que a gente protegesse esses aglomerados, né, essas comunidades, e não acontecesse o que era nosso maior risco e a hipótese que a gente tinha aqui, que de quando essa doença chegasse, então seria um grande surto, iria lavar esses espaços, levando ao óbito, porque também são espaços onde a gente tem questões importantes de imunodeficiências alimentares, enfim. Desde o início, nós tivemos ações educativas fortíssimas sobre as medidas protetivas. E isso fica muito claro também na sua apresentação: o uso de máscara, a higienização das mãos, o distanciamento. Como que isso foi importante? E como que isso não é uma medida apenas do governo? Por mais que, enquanto gestão, a gente coloque a obrigatoriedade nos espaços da circulação dessa forma, se isso não for compreendido pela população, se isso não for feito um processo de adesão da população a essas medidas, com uma mudança cultural, é muito difícil da gente implantar. Então, nós percebemos uma mudança cultural dos hábitos da nossa população, que realmente aderiu ao uso de máscara, ao processo de higienização das mãos e o distanciamento em diversos espaços. E isso fez com que a gente também pudesse, num determinado momento, começar a pensar alguns processos de retomada. A experiência que o senhor conta, né, da ação educativa, né, dos episódios do projeto da Unicef, né, e esses episódios que foram televisionados, pegando toda a população, eu fiquei pensando como que poderia ter sido mais assertivo, mais possível de vencermos o Covid de uma forma talvez um pouco mais branda, se tivéssemos tido uma orientação nacional, uma coordenação nacional desse processo de enfrentamento. Infelizmente, no nosso país, esse processo de enfrentamento ele ficou muito a cargo das coordenações estaduais e municipais, em termos dessas ações mais direcionadas à população. Então, fizemos, sim, ações educativas como essa, mas voltadas nas nossas próprias mídias municipais, nas nossas ações municipais. Demorou-se muito para que no país a gente tivesse uma ação coordenada nacional como essa, por exemplo, que o senhor relata da Unicef. E como isso é importante? Porque o enfrentamento ao Covid, ele é uma grande ação educativa, né? O enfrentamento a conseguirmos exterminar esse vírus e vivermos livres dele é num processo educativo muito grande, que combinado com, claro, um processo de controle e de vigilância epidemiológica. Então, essa combinação da saúde pública, da epidemiologia, com medidas educativas, ela é fundamental para que a gente tenha sucesso. E eu fico pensando quais outras, né? Você citou a questão dos agentes, os episódios da Unicef, quais outras medidas educativas foram também sendo desenvolvidas aí ao longo desse processo? Você cita que conseguiu conter a migração das áreas rurais para urbanas a partir do momento que conseguiu sanar as áreas rurais, né, da questão alimentar, da questão do lockdown, das orientações. Aqui nós tivemos, né, no país de uma forma geral, uma migração grande das áreas urbanas para os interiores, por uma característica específica que a gente tem das residências, né? E no município de Niterói também não foi diferente. A gente teve alguma migração das áreas mais centrais para as áreas mais praianas, por uma questão, muitas pessoas migraram de apartamentos para casas, buscando mais espaço, famílias que, por uma questão financeira, se aglomeraram, no seguinte sentido, né? 2 casas se tornaram uma casa só para conseguir garantir essa subsistência, né? Essa sobrevivência familiar. Então, isso foi algo que observamos aqui. Dessa forma, nós tivemos uma segunda onda no estado do Rio de Janeiro, que foi no interior. Então, enquanto na primeira onda, ainda em 2020, no estado do Rio de Janeiro, a gente teve a maior concentração de casos, de óbitos, de agravamento nas regiões metropolitanas, próximas à capital, na segunda onda, ainda no primeiro trimestre de 2021, essa característica do agravamento ela foi para o interior, onde a gente viveu uma saturação muito maior dos serviços de saúde. Primeiro, porque esses serviços de saúde já estavam estressados e esgotados com quase 1 ano de pandemia. E segundo, porque realmente no interior a gente tem maior limitação dos leitos e, então, do acesso. Por fim, eu fico pensando assim, não há a questão das escolas, né? Você cita que as escolas elas começaram a ser reabertas agora, esse ano de 2021, entre agosto e setembro. E aí eu fiquei me pergunto aqui, por quanto tempo elas permaneceram fechadas para as aulas presenciais? Quais foram as estratégias utilizadas para o processo educativo desses alunos? Principalmente quando a gente fala das séries iniciais, ou seja, das crianças de 3 a 7 anos. Como foi esse processo educativo? No Brasil, nós já temos estudos apontando para um retrocesso de 1 década no processo de ensino-aprendizagem, na evolução da educação no país, pelas medidas de ausência. Por quê? Nas redes públicas, não conseguimos, na maior parte dos lugares, fazer uma transição adequada do ensino presencial para o ensino à distância. E isso gerou, sim, desassistência a essas crianças e esses jovens. Isso gerou perdas educacionais importantes nesse processo histórico que o Brasil já vinha enfrentando. Isso é algo que a gente vai ter que, nesse momento, enfrentar e lidar com muita tranquilidade de como vamos desenhar os próximos passos do sistema educacional brasileiro na perspectiva de resgatar e recuperar esse processo que foi, de alguma forma, perdido. Não digo que tinha outra forma de se fazer, né? Acho que fechamos as escolas no momento oportuno, não tínhamos como fazer de outra forma, e reabrimos, e aí cada município, mais uma vez, numa ação não coordenada nacionalmente, mas muito a critério dos municípios e estados. Cada município e estado fez esse processo de retomada das atividades presenciais de acordo com seus critérios, com seus comitês científicos. Aqui em Niterói, nós fechamos no dia 14 de março de 2020, fechamos ainda antes de iniciar em Niterói a primeira onda. Na semana que detectamos o primeiro caso, nós fechamos as escolas, fizemos um processo de retomada das escolas em outubro para as séries finais, ou seja, para o ensino médio, e retomamos em fevereiro de 2021 as séries iniciais. Ao longo desse ano, em alguns momentos, fizemos algumas suspensões de aula, mas sempre com o norte de entender a educação como atividade essencial. Nesse momento, ainda no final do ano passado, houve uma compreensão do nosso gabinete de crise, junto ao nosso comitê científico, de que precisávamos reposicionar as escolas, a educação, como uma atividade essencial. Então, poderíamos fechar outras atividades, diversos segmentos e setores, de acordo com a necessidade, mas deveríamos manter a educação com algum nível, algum grau de atividades presenciais abertas. Dessa forma, criamos protocolos muito rigorosos, rígidos, para as escolas, para as famílias, para os alunos, e mais do que isso, elaboramos um sistema de vigilância escolar que faz especificamente o controle de todos os casos que acontecem, suspeitas de caso, nas escolas, com um processo de rastreamento rápido, isolamento e, se necessário, suspensão de aluno, turma, segmento e escola, num período de quarentena. Dessa forma, é com muita alegria que a gente fez o último relatório essa semana, onde nós temos raríssimos casos nas escolas de Covid. E com um processo, e quando a gente vai investigar, essa transmissão não é feita dentro do ambiente escolar. São casos externos que são notificados à escola e a gente investiga e já está em isolamento, nem chega a ir para a escola. Então, assim, a gente retomou nesse processo, que foi bastante importante. Então, vamos dar agora mais um passo grande, que é, a partir de novembro, uma retomada 100% das atividades presenciais nas escolas. Então, assim, esse reposicionamento da educação, ele foi fundamental frente à nossa dificuldade de fazer uma educação de qualidade num processo à distância, que é uma realidade que a gente vive, né, no nosso país, principalmente no recorte das redes públicas, né? E aí, mais uma vez, a gente está falando da necessidade da participação social, ou seja, como que esse processo da retomada das atividades escolares, ele só é possível se eu tenho junto dele toda a comunidade escolar, colaboradores, professores, diretores, gestores regionais, território e as famílias, né? Então, ele só é possível se todos têm consciência. Então, dentro dos protocolos, se a criança tem uma coriza, se ele tem uma dor de barriga, ele não vai à escola. Se ele tem contato nos últimos 3 dias com qualquer pessoa com suspeita, ele não vai à escola. Então, essas medidas de proteção, elas passam por um processo de consciência social, empatia, que tivemos que desenvolver na nossa comunidade. E a outra coisa é que o mesmo processo nós fizemos para a retomada de algumas atividades. Caminhar para a eliminação do coronavírus é também caminhar para um processo de consciência coletiva sanitária. Precisamos entender que cada um de nós que habitamos nessa cidade é responsável sanitário por conter o coronavírus nessa cidade. E essa foi a premissa que nós utilizamos em todo o processo, ao longo desses quase 2 anos, de comunicação com a população, com os setores produtivos, com os trabalhadores e também no setor da educação. Acho que estamos caminhando nessa direção. Estamos aí hoje, 6 dias, sem nenhum óbito de Covid no sistema público do município. uma queda muito grande, um município que já teve, só na rede pública, mais de 150 pacientes internados, hoje temos menos de 30 pacientes internados, né? A transmissão de casos, ela ainda acontece, mas em queda, numa queda bem importante, diminuindo a cada semana o número de novos casos e diminuindo radicalmente o agravamento desses casos. Claro que tudo isso combinado com uma estratégia de vacinação bastante ousada, bastante agressiva no município, ainda também, mesmo apesar de uma falta de coordenação nacional desse processo de vacinação, nós conseguimos avançar e também com muita alegria, amanhã estamos concluindo toda a vacinação, né, das doses acima de 12 anos, que é o que é preconizado no nosso país, da segunda dose acima de 12 anos, da dose de reforço de todos os idosos acima de 60 anos e dos profissionais de saúde. Com isso, a partir da próxima semana, a vacinação da Covid passa a ser incorporada como rotina nas nossas salas de vacinação. Ela deixa de ser essa grande ação, né, que exigiu muito esforço da gestão, muito esforço dos profissionais, muitas unidades funcionando de segunda a segunda, e passa a ser incorporado na rotina da sala de vacinação, num processo ainda de busca ativa e repescagem, mas de grande respeito à população, que teve uma adesão enorme à nossa campanha de vacinação, tanto na primeira dose quanto na segunda dose, e eu acho que é nesse espírito coletivo que a gente vai conseguir eliminar o coronavírus e vencer todo esse processo de pandemia que nos tem acometido. Obrigada.
Muito obrigado, Camila. Uma excelente apresentação, não só provocativa em termos de reflexões da experiência indiana, mas também da experiência de Niterói. Acho que está de parabéns por esse trabalho e essa capacidade de alinhar a gestão com a comunidade é fundamental. Acho que fica claro tanto na experiência de Niterói quanto na experiência indiana. Nós já temos algumas questões aqui no chat, mas antes de passar essas questões, eu queria perguntar ao Sunil se ele gostaria de reagir, de comentar alguma das muitas questões já trazidas por Camila. Sunil, por favor, a palavra é com você.
Thanks, Lois, for inviting me at this point in time. I was listening to her, and it was an engrossing talk, to be very honest. It was clear. Now, most of the times, where we commit mistake as public health specialists or those who work in the field of public health, we make mistakes that the models for better healthcare delivery exist only in the rich and elitist class. So the best model across the world will be delivered to us by those who have the highest amount of resources or who are tech savvy, who are the technological advantage. We tend to forget that within the resource constrained people, or within the realm of resource constrained societies, the chances of having a model which is sustainable are more likely than those who have higher resources. So when I listened to Camila, I could understand that within those limitations that are similar to probably Brazil and India, they could develop some models which could be universally applicable. For example, the student surveillance system, which is very good, because at the end of the day, we will need to decide whether we want to take students to school without vaccination or not. We need to probably understand the difference between risk quantification and risk mitigation. And therein, we will need to take the students to school without having them vaccines. When I talk of India, so if I have to vaccinate my children or my kids in India, I would need, how many doses do I need? If I am using a 2-dose vaccine regime, I would probably need 1.8 billion doses, which is huge numbers to take care of. So it will take me many, many months to deliver those. So do I take my students to the school before that, or do I wait for that? So if I have to take them to school before that, I will need to have something which you people have developed there in Brazil. So probably this story needs to be told across the world. Stories like these, which are workable in resource constrained settings and can be replicated across the world, than models or stories coming from rich countries, which are not replicable across the world. So probably that was probably one of the key takeaways from this talk. Exceptional. Thank you.
Muito obrigado, Sunil. Eu gostaria de apresentar duas questões que surgiram aqui da audiência. A primeira se refere à existência de posicionamentos contrários à adoção dessas medidas. Se houve resistência, seja de setores políticos, seja de setores econômicos, por exemplo, os comerciantes, ou algum partido político, grupos políticos, se houve manifestações ativas de resistências a essas medidas, como o caso do Brasil. No Brasil, nós tivemos muito debate político, muita mobilização, também contrária a qualquer medida de lockdown, qualquer medida de restrições, inclusive de uso de máscara, a gente sabe disso. Houve essa experiência também? Vocês enfrentaram esse tipo de resistência? Essa seria uma primeira pergunta. Uma segunda pergunta se refere à existência prévia de um sistema de atenção primária bem constituído, forte, atuante na Índia. Se isso já existia antes ou esse foi mobilizado a partir da emergência da pandemia de Covid-19. Nesse caso, como é que funciona a atenção primária à saúde, esses trabalhadores de saúde comunitários, como é que funcionavam antes da pandemia, se houve alguma mudança específica para a atuação deles durante esse período da pandemia. Não sei se ficaram claras as questões, qualquer coisa, por favor, sinalize, mas gostaria de ouvi-lo.
Thank you. First, we come to the first question. I have a belief that it's much more easy to talk to politicians than to scientists or doctors who turn bureaucrats or who turn to think that they are advising the politicians. So the difficulty with the current system across the world that I feel is that a group of people who think that they're advising the governments, they think that they know everything. And this fact that they know everything about the pandemic, about the healthcare crisis, is something that is not delivering the right message to the politicians. Otherwise, if politicians are told the correct things, if they are told the correct messages, if they're allowed to think on their own, that this is my take on it. If they're allowed to think on their own, it is much more easy to convince them. Now, luckily for India, what we had was we had a prime minister who was more or less convinced on lockdown, and he was more or less convinced to take it to everybody in the country. Now, what I mean by that is that if we would listen to, we started in March, in the end of March, we started the lockdown when the number of cases in India was 500 only. Before we went on a nationwide lockdown, we went on a self-curfew or Janta curfew, which the Prime Minister initiated. He said that let us impose a self-restriction on ourselves to stop moving from our homes for 1 day. So for 24 hours, he said that how many of you are willing to listen to me and they don't move out of their home. This was probably on 22nd of March. So this was probably a rehearsal to getting into the lockdown. And then we went into the lockdown on 25th. So the politicians being convinced and being able to convey it to the people is probably the key. Because believe me, people generally tend to trust politicians if the politicians are delivering the correct message more than the scientists at any point in time. So the key was that what I always say when I talk about this is that India followed more or less a circular system of communication. It didn't follow a top-down or bottom-level communication system. So it was not that communication came from the bottom level and it was communicated to the Prime Minister, and Prime Minister communicated it through his ministers or bureaucrats and then to state-level officials, and these state-level officials will talk to the lowest level of official and then to the people. No, it didn't work like that. Here, the Prime Minister was directly talking to people on a daily basis. You would be surprised. You would see hear the Prime Minister's voice in the telephone messages that you would send to each other. So if you would call me, for example, from Brazil, you would not hear my voice first. You will hear the voice of my Prime Minister or you will hear the voice of a politician, or you will hear the voice of a celebrity who will talk of vaccination, who will talk of lockdown. For a major part of it, when the lockdown was lifted, the one voice that rang in the in our telephones was that of our Prime Minister. It said that the lockdown has been lifted, but Corona is still there. So probably the way messages are delivered and the way messages are carried down to the bottom is the key as far as response of the people is concerned. The success of managing this pandemic, not just this pandemic, also the fact that we have been able to achieve good success as far as vaccination is concerned, is that people submitting to guidelines and trusting the intent of the government is something that is very important. And that is probably where India was helped. We did not have street level agitations on that. Why should there be a lockdown? People more or less accepted lockdown as something which was necessary and important to keep down the pandemic. So at no point in time had we have problems with people refusing lockdown, neither the industry, nor the common people, or nor anybody else. So all of them submitted to lockdown as if this was necessary, because of the fact that probably it was conveyed to them in a very correct way, or it was conveyed to them on a daily basis from top leadership down to the basics. So that was something that helped India probably. The second part of your question, the second question was about primary healthcare system. How does our primary healthcare system work? Now, you need to understand it this way. Now, India at this point in time has around 28 states and 8 union territories. Union territories are something which are directly under the control of the central government or the federal government. The 28 states are ruled by their own state chief ministers, which may be of any party, which may be of the same party which is ruling at the central government, or maybe of different parties. Now, these 28 states and these 8 union territories have around 600 medical schools or medical colleges. That's what we refer to in India. And that is probably forms the tertiary care setup that we have in India, in addition to the private health system that we have that works as far as tertiary care setup is concerned. Then there are district level hospitals, which are again secondary and tertiary in their outlook. They deliver both secondary and tertiary care. Then below the district levels, we have the sub-district levels or community health centers, which are known as the CHCs or the sub-district hospital levels facilities. Now, these community health centers across the country, if you look at, they are in excess of some 3,700. So they are a huge number again. These are at the block level, or wherein the population ranges from between 80,000 to 120,000. So they are placed at that level. Below a community health center is a primary health center. Now, this primary health center is supposed to deliver the primary care that you were talking about, as also community health centers do also deliver primary care. So every state has huge number of primary care centers. So if you look at a country, the number of primary care centers may be in excess of 35,000. This is the number of primary care centers that we have across the country. Below the primary care centers, we have the sub-health centers, the SHCs. So every primary health care center has around 4 to 5 sub-health centers under this. Now, these sub-health centers deliver preventive and promotive care for a population of around 5 to 10,000. The PHC is manned by a medical officer. So you have an MBBS doctor who sits at the level of primary health care center, which takes care of around 20 to 30,000 of population. Below the primary health care, we have primary health center, we have the sub-health center, and sub-health center is manned by an ANM, which is auxiliary nurse midwife or a health assistant. So they are paraprofessionals who work in these sub-health centers. Now, in last 3-4 years, what we have done is that across the country, we have launched the universal health coverage through what is known as Atal Bihari Pradhan Mantri Jan Arogya Yojana, ABJ, Atal Bihari ABJMAY. This is something that we have done in last 3-4 years. Now, under these, what we are doing is that we are converting these sub-health centers, which are at the population of around 5 to 10,000, 3 to 5,000. We are converting them into health and wellness centers. So across the country, we are developing 150,000 health and wellness centers. Now, each health and wellness center will be manned by a community health officer. So CHO or community health officer. Now, these community health officers are nursing professionals or nurse care practitioners, who undergo a training of 6 months to be able to deliver healthcare at the level of these health and wellness centers. So the government of India is funding all of this program. These 150,000 health and wellness centers across the country are being developed through a program developed by the government of India across the country. If you go below this health and wellness centers, you have the village levels, and roughly a village is the population of around 1,000 people. This 1,000 people is being delivered by or taken care of through these ASHAs, or accredited self-help social health activists, ASHA, which I talked about in my talk also. So these ASHA workers deliver basic health care at the level of villages only, village level, and it takes care of around 1,000 people only, so not beyond 1,000 people. So below sub-center are these ASHAs, as also other healthcare workers who are not directly a part of health. For example, village health and sanitation guides are there at the level of village, who take care of public health in terms of providing sanitation. So they are again a part of the system, but not directly a part of the health. But ASHA is something which mostly deals with health at the village level of the village level of each village. So across the country, if you look at if you look at my state, which is much smaller in number, it has around 707,000 ASHA workers across its villages. If you look at Uttar Pradesh, which is much larger, much bigger, it has around 170,000 ASHA workers who are spread across the villages. So the number of ASHA workers spread across the villages is huge. This is all a part of the scheme which was developed to deliver healthcare at the level of primary care only. So they don't treat patients, these ASHA workers, but they take care of, for example, identification of COVID patients was given, the duty of identification of COVID patients was given to them, or we give them the task of identifying active case finding in terms of tuberculosis. So they go house to house and search for active cases of tuberculosis, or they are asked to screen people for blood pressure, or they are asked to screen people for raised blood sugar or diabetes or hypertension. So this is something that they do at the village level, take them to the sub-center level or health and wellness center, and beyond the health and wellness center, you have the PHCs, which are manned by the healthcare professionals. So probably this is how our primary healthcare works, and this has always been in existence. That is why I said at the initial step itself that India may have been helped by the fact that over a period of time, it has built a system which was robust in a sense to deliver in the pandemic. So the success of being able to reduce the number may not be given to the on-hand management of the current pandemic, but also to the fact that over a period of time, we built a system which was able to take care of this pandemic. I give another example, which may not be directly related to it. Now, over a period of time, for example, when it started for the first time, the only facility that could deliver RT-PCR testing in India was one. So that was in National Institute of Virology. So we had only one testing facility. But over a period of time, what Government of India had done was it had started the viral diagnostic reference labs, research labs across medical colleges in India. So roughly 120 medical colleges in India had these VDRL labs, which were established by Government of India, as also multidisciplinary research units, MRUs, which were established across another 100 medical colleges in the country. I'm in charge of one of these MRUs in my medical college. Now, once the pandemic came, these labs were strengthened to do the testing as far as RT-PCR was concerned. So we could escalate, or we could scale up the number of testing, or the number of tests that we started initially to high numbers, because we had these in place, because we had the VDRL and MRU in place. So probably the fact that we had the advantage just because of the system was built prior to the pandemic, and we could use that system, may have been of an advantage to us. I hope I have been clear on this.
Sim. Muito obrigado, foi muito esclarecedores, suas informações foram bastante esclarecedoras. Queria passar uma pergunta para a Camila, que veio aqui do nosso participante. Camila, quais fatores vocês acreditam que tenham sido responsáveis pela adesão em Niterói, mesmo com os problemas de coordenação nacional?
Eu acho que o principal fator foi muito bem relatado por Dr. Sunil sobre a questão da confiança da população na liderança do gestor, né? Então, assim, apesar da coordenação nacional, nós assumimos esse processo de comunicação, né? Nós, da gestão, assumimos esse processo de comunicação com a população. Então, foi instaurado, no mesmo dia que foi decretado o lockdown, o gabinete de crise. Esse gabinete de crise era um gabinete composto pelos secretários intersetorial, liderados pelo prefeito, à época o prefeito Rodrigo Neves, e ele se reunia diariamente para trazer análise e traçar as ações de combate. E ao final da reunião do gabinete de crise era feita uma audiência para a população, através das redes sociais. Então, diariamente, o prefeito, os secretários se comunicavam com a população, orientando, dando tanto o painel da Covid naquele dia, naquele momento, do nosso município, nacional, estadual, como também as ações de combate, chamando a população, convocando a população para esse enfrentamento conjunto. Então, eu não tenho dúvida de que a confiança na liderança, no governo, foi um fator determinante para que a população acreditasse que estávamos, então, juntos nesse enfrentamento. E é um pouco o que o doutor Sunil falou, né? A população escutava a voz, né, quando ele cita a voz do primeiro-ministro. Aqui a nossa população escutava diariamente a voz do prefeito. A voz do prefeito falando, precisamos fazer isso, isso e isso. E juntos vamos conseguir vencer. Então, essa convocação, e juntos vamos, e fez com que tivesse essa grande adesão, né? Então, eu não tenho dúvida que esse processo de comunicação ele foi fundamental. Claro que isso também junto com as medidas de proteção e segurança social. Então, esse conjunto possibilitou esse processo de confiança. E quando a gente faz, né, aquela questão que você colocou das medidas contrárias ao lockdown, nós vivenciamos isso no contexto no Brasil de uma forma muito forte. No município de Niterói, nós tivemos pouco movimento, algum movimento, mas pouco movimento contrário ao lockdown. Não tivemos resistência ao fechamento das atividades. As atividades, nos momentos certos, foram, sim, interrompidas, e no momento que retornaram com restrições, com protocolos, uma a uma, não todas as atividades ao mesmo tempo. A última atividade produtiva retornou agora, dia 1º de outubro, ou seja, mais de um ano fechado esse setor. E, assim, nesse processo com os setores econômicos, também tinha reuniões semanais. Então, semanalmente, era reunido setores de restaurantes, setores da saúde privada. Então, cada setor tinha sua reunião semanal, onde era feita a escuta das angústias desse setor, das dificuldades desse setor nesse processo, e, ao mesmo tempo, era aberto esse canal de diálogo, onde era colocada a importância desse setor também nesse momento. A partir dessa escuta, algumas políticas, algumas estratégias de proteção econômica foram feitas, que também possibilitaram que o setor fizesse essa adesão ao movimento, sem dúvida alguma. E também, no momento de flexibilização, quando ele chegou, esse diálogo com o setor, esse canal de diálogo já existia. Então, o como retomar, em que medida, quando, quais os protocolos, quais as medidas de proteção, tudo isso foi fortemente aderido tanto pela população e pelo setor econômico. Então, eles passaram a ser também responsáveis pela manutenção da sua atividade econômica. Caso os protocolos, caso os indicadores mostrassem outra tendência, novamente essa atividade seria restrita. Então, essa corresponsabilidade no processo de retomada foi fundamental. E essa sinalização, essa construção dessa parceria liderada pelo governo cria uma confiança. Eu não tenho dúvida que essa confiança é uma base importante da adesão da população e dos setores econômicos.
Obrigado, Camila, ficou muito claro. Tem mais uma pergunta para o doutor Sunil, na verdade, mais duas perguntas. A primeira se refere ao acesso às áreas rurais, às regiões rurais. se houve alguma dificuldade maior e que estratégias foram usadas para, de fato, fazer chegar as informações e os serviços às comunidades rurais. E a segunda pergunta se refere à vacinação. Como está a vacinação na Índia e se tem tido um desempenho tranquilo, ou se há também movimentos anti-vacina que têm atrapalhado ou prejudicado o desempenho da campanha, das ações de vacinação. Por favor, Sunil.
I think the second question will answer the first as well. So how has been the vaccination in India? I think vaccination in India has gone well. And for a large part, our limitation with vaccines was that we didn't have a finite supply. We didn't have an infinite supply of vaccines. The supply of vaccines was finite and it was fixed, and we were building on the vaccine capabilities as far as vaccine delivery was concerned. You may be aware we had largely two vaccines to rest on. We had the Indian-made Covishield, and we had the, again, Indian indigenous vaccine, which was the Covaxin, which was being delivered in India. Now, the capacity of both these companies to deliver vaccines on a monthly basis was not of the highest level in the initial phase. And it was only, I think, by the month of September that we did have the manufacturers of Covishield being able to deliver us around 200 million vaccines in 1 month time. So in that sense, we did have difficulties as far as vaccines were concerned, but vaccine supply was concerned. But as far as delivery and execution of vaccination was concerned, it was not a difficult job. Primarily because of the fact that we probably run the biggest, India probably runs the biggest vaccination program as far as kids are concerned. So we have been very successful with running our vaccination program for our under 5, and building that on an experience from that was huge for us. We didn't have anti-vaccine problem in India. Nobody opposed vaccines. In fact, people wanted to have vaccines as early as 16th of January when we started. People did want to have vaccines. I think that we need to understand vaccines in one term. That's how I understand vaccines now, because as I said, I have been involved with vaccination part from day one in my institute also. I was in charge of that. I continue to be in charge of the vaccination process. So we need to understand vaccination in these terms. When the deaths go high, or when the number of cases go high, the demand for vaccines is the highest. When the deaths go low, or the number of cases go low, then the demand for vaccines is also low. So this is something that works probably what we define as the precautionary principle. People fear death, people fear the default setting, then they look for everything. And vaccines is probably the biggest tool in their hand. So we have been able to deliver vaccines across the country. And a few days back, I was on a television channel in India. I said the best part of India's vaccination program is the equitable delivery of vaccines. So across the world, we see problems that there is difficulty in being able to deliver vaccines to some sections of the society, some parts of the country, some geographical areas of the country. In that sense, we didn't have a problem, because you will be surprised that the distribution of vaccines in India has been more or less uniform. 60% of vaccines have gone to the rural areas in India, while only 40% of vaccines have gone to the urban areas in India. So we have more or less a uniform distribution of vaccines, although we would have wanted it much better, because 70% of our, almost 70% of our population lives in the rural areas. So I would have wanted more higher numbers as far as rural areas is concerned. But still 60% is a good number. This has probably been helped by the fact that also that the vaccines are being delivered free of cost in India. So all of us are getting our vaccines free of cost, and they're being taken to the places wherein these vaccines are delivered. You'll be surprised that in one of the areas that in the state wherein I live, one of my areas is not accessible through road. It has to be accessed for a very short period of time. It is available to be accessed through road. For the rest of the times, it's closed for access through road. So the vaccines there were delivered by heli-taxis, and the vaccines were delivered by the district collector, or what you would like to refer to that in Brazil is district governor, something like a district governor, the official head of the district. He himself went into that helicopter and delivered the vaccines to that place. So probably in that sense, vaccination has been good, and we have been able to cross the 1 billion mark. We are close to 1.3 billion now. A large people have received the first dose of vaccines. Around 30%, 30 to 32% people have received the second dose of vaccine. Those who are eligible have received the second dose of vaccines. So in that sense, vaccination is good, but I still feel that the vaccination will need to take care, we need to go up. The production has to go high if we are able to deliver vaccines to everybody in India, because the numbers are huge. And we are still not thinking of the third dose, what people refer to as the booster dose. I generally don't want to agree with those words, the boosters or the third dose. So we still have not thought about the third dose. We are currently focusing on delivering of vaccines to kids, and in fact have given authorization to two companies, in fact 3 companies, to deliver vaccines to the kids. And we may be starting vaccination of kids very soon, wherein one of the companies will be giving vaccination to children about 2 years of age, and another company is going to deliver vaccines to kids between 12 to 17 years of age. So that's something that is in the pipeline. Initially, you are thinking of targeting kids with a comorbid condition only. So we are going to vaccinate kids with comorbid condition only, and then on expand it to other kids as well. So that's how vaccinate. But to be very honest, we never ever had vaccine hesitancy or anti-vaccine campaign in India. People here are wanting to have vaccine more and more.
Muito obrigado, doutor Sunil, doutora Camila. Nós estamos já próximos da nossa conclusão. Eu queria só fazer uma última pergunta para ambos. Nós tivemos um pico do número de casos no Brasil e também na Índia no primeiro trimestre de 2020, e tivemos, enfim, uma série de medidas foram desenvolvidas, e tivemos já no primeiro trimestre também de 2021, na China ou na Índia, em abril, maio, tivemos um novo pico dessa pandemia. Nós teremos, então a pergunta é, nós seremos obrigados a conviver com esses altos e baixos, ou há, de fato, uma possibilidade de eliminação do coronavírus de uma forma prolongada, digamos assim, sem a ocorrência desses picos a cada ano ou a cada período de 6 meses? Como é que vocês veem a possibilidade dessas medidas de eliminação dos vírus terem um sucesso prolongado? Se o Sunil gostaria de começar.
I'm of the opinion that every country across the world should think elimination. It shouldn't think of living with the virus. That's not the way to go with this virus. And the best way to elimination is to reduce the numbers, keep reducing the numbers. Now, when we saw India's second peak, so despite the fact that we put a large blame on the fact that Delta may have been the responsible factor for creating the second wave, but I keep saying it, that the initial part of every wave will be led by the current circulating vaccine. It won't be the new vaccine, or it won't be the new virus or new strain of the virus. The initial part of the wave will be because of the currently circulating virus strain only. So the key is probably to keep the numbers to as low as possible. So how do we keep the numbers to as low as possible? So in the event of the fact that we have opened up, this is something that is a reality now. We have opened up. So the best way to keep the numbers to as low as possible is to adhere to the guidelines. So if there are guidelines for shopkeepers, they need to be adhered. If there are guidelines for shopping malls, they need to be adhered. If there are guidelines for schools, they need to be adhered. If there are guidelines for individuals, I see this happening in my part of the country as well. As the numbers have gone down, the precautions have gone down as well. As the numbers were up, the precautions were up also. So you see people now roaming around without masks or not using masks correctly. Even if they are carrying the mask because of the fact that they fear that they will be fined, they carry the mask, but the mask is not worn correctly. The shops have opened up, and as I kept telling people in my state that we don't need, I live in a state which is quite hilly in sense, and it doesn't have huge temperatures. So I keep telling my people in my state that we don't need air-conditioned shopping malls. We don't need air-conditioned shopping centers. So we can, at some point in time, open them up. We don't need these. So probably adhering to these guidelines, putting restrictions on on the movement of people, not thinking that it is over, will be the key. And elimination is the only way to think about this pandemic. Now, there is no other way of tackling this pandemic. Because if we don't think of elimination, if we let people start living with the virus, there is always a chance that we will have the numbers going up, we will have the new strains coming up, and then there are a peak again. And then there will be the trough and peak again. So we need to keep thinking elimination, and strictly adhering to the guidelines will be the key. The COVID appropriate behavior should be the guideline for all of us to follow for next 5-6 months at least.
Muito obrigado, Nil. Camila, por favor.
Acho que, sem dúvida nenhuma, manter as medidas de precaução é uma das primeiras coisas que tem que serem pensadas para a eliminação. Então, assim, inclusive, todas as experiências de retomada de países que iniciaram pela eliminação da máscara tiveram que recuar nesse processo. Então, assim, o uso principalmente da máscara, ele precisa ser incorporado no cotidiano. E isso não só para a eliminação do Covid, como também como que esse uso de máscara, ele possibilita evitar diversos outros vírus respiratórios. As crianças adoeceram muito menos nesse inverno, né? Os indicadores de doenças graves respiratórias melhoraram nesse inverno. E não é porque as doenças pararam de circular, mas o uso da máscara impede esse contágio, e dessa forma a gente vai realmente eliminando não só o Covid. Então, essas medidas de precaução que a gente está falando são medidas higiênicas, são medidas de etiqueta respiratória. Elas precisam vir e ficar, e permanecer, para o combate ao Covid e diversas outras doenças também. Então, essa eu acho que é uma das estratégias que precisa ser pensadas, que precisa ser comunicada, e ela precisa significar uma mudança cultural importante. E eu não tenho dúvida que um processo de imunização completo, ele é uma forma da gente buscar essa eliminação. O que eu chamo de processo de imunização completo? A gente tem as 2 doses. Qual é a resistência disso dentro, numa possibilidade de um novo contágio? Então, a gente precisa começar a cruzar essas informações e esses achados, tanto a respeito da resposta imunológica quanto da transmissão do vírus, para caminhar numa eliminação, a partir também da incorporação desse processo de imunização no calendário vacinal, da mesma forma como a gente fez com todas as outras doenças que fazem parte do nosso calendário vacinal, assim como H1N1, assim como a vacina de gripe. Então, a gente precisa pensar já no futuro como que vai ser esse calendário vacinal. Não dá para a gente continuar vivendo uma campanha. Doutor Sunil, eu fiquei aqui com inveja quando o senhor falou de 220 milhões de doses no mês. Né? Aqui a gente conta a dose todo dia para ver quantas que a gente consegue vacinar naquele dia. Então, assim, a gente precisa pensar de uma maneira mais estratégica esse processo de incorporação da imunização do Covid no calendário vacinal.
Muito obrigado, Camila. Acho que a mensagem é muito clara. E a World Health Network, né, a rede Covid aqui no Brasil, todas estão mobilizadas nesse sentido, de dizer que é preciso eliminar o vírus. Não podemos aceitar a convivência com o vírus, centenas de mortes todos os dias, pessoas atingidas pela Covid. Isso é inaceitável. Portanto, as medidas de prevenção, de proteção, continuam necessárias. A gente não pode deixar um pequeno fogo aceso, que isso pode se tornar um grande incêndio. É a imagem que tem sido utilizada nesse sentido, para continuar firmes em busca da eliminação da Covid e da pandemia no mundo todo. Eu quero agradecer muito a participação, a presença do Dr. Sunil Raina, que é membro da World Health Network, também da Camila, subsecretária de Saúde de Niterói, sanitarista, e desejar a todos que nos acompanharam, agradecer também o acompanhamento, desejar a todos um bom dia e firme na luta contra a Covid. Um grande abraço a todos.
Thank you.
Obrigada. Um abraço.